Research Commonwealth Medical Fellowship, UK, in strokes, epilepsy, and clinical neurophysiology. He is a fellow of Royal College of Physicians, Edinburgh, fellow of American Academy of Neurology, fellow of Indian Academy of Neurology, fellow of Madras Medical College, former professor head Institute of Neurology, MMC, and Government General Hospital, Chennai, former professor and HOD Neurology at Chetnad Academy, and he is our emeritus professor of our university. His areas of interest are stroke, epilepsy, headaches, and Parkinsonism. His topic for today is dizziness unraveled, and the discussion panelists will be Dr. Jawahar Marimuthu, Professor of Neurology from Institute of Neurology, Madras Medical College, and K. Mukundan, sir, Head and Professor of Neurology, Stanley Medical College. Over to you, sir. Share பண்ணுங்க.
Welcome, sir. Professor V. Nadarajan, my great
Welcome,
teacher and retired director, Institute of Neurology, Madras Medical College. I'm really very happy to interact with you, sir. I really like to hear your lecture after a long period of time. Thank you, sir.
Thank you, Dr. Jawahar. Thank you, Professor Jawahar. I wish to thank the Vice Chancellor of Tamil Nadu, Dr. M.G.R. Medical University, for having asked me to give this talk. I am also grateful to her department people who have arranged all this talk, this webinar, and I am really grateful to them. I also welcome Professor Mukundan, another great friend of mine, and welcome all the delegates, all those who have come tuned in to listen to what I am going to say, and good afternoon to all of you. Shall we have the first slide? Yes. Shall we go to the next slide, please? Right. Now, dizziness, as I was just saying, is a symptom with which patients come to us or to any one of us who is in practice. It doesn't need to be a specialist. It can be a practitioner, it can be a physician, it can be anybody. And most often what they come out is with the symptoms saying, these are the two common words they are often used, GER, mayakam. And we have to probe into it to find out what this GER means, what this mayakam means, because to each person, it means a different thing. And many a times they are not able to give a proper description of what exactly they are feeling. GER, they accept it as a common term, saying that anybody could understand, the doctor could understand what is a GER. So also mayakam. Now, what exactly is this GER and mayakam? What are all the descriptions that fits in with this? Are these following? It can be a vertigo, which is what very often we come to the conclusion. Anybody saying it's a GER or mayakam, we think it is vertigo and put them on labyrinthine serratus, beta histines. This is what is commonly done. But it need not necessarily have to be vertigo. It can be a pre-syncopal condition. We'll see what is a pre-syncopal condition. Or it can be a disequilibrium state, which is quite common. And non-specific dizziness. In fact, the non-specific dizziness is what? It is not a vertigo. When you ask specifically, is it a spinning sensation? They would say no. When asked whether you spin, no. Then what exactly is it? Do you lose balance? Yes, most often they say. Sometimes they come and say they are not able to say what that symptom is. Something is happening. I'm not able to say what is happening. So these are all the conditions or symptoms which is in the term GER or spin or mayakam. So to understand this, we need to have a clear description from the patient. And not alone the description of the symptom. What exactly is happening to you? You describe it. Or we can ask leading questions. Thala suttuda, paakradala sutra madri irka, illa ullukulla sutrada, illa thallrada, illa ennatham pannadu. What else is happening? So most often one of these things will be there, but most common as far as clear vertigo, yes, it's easy, but most often they would say thalludu. That is what we miss often. We include the thalrudu, which is an imbalance or a disequilibrium, to be misconstrued to be a true vertigo and treat them with beta histines or labyrinthine sedatives, which is not going to be that much helpful for them. Okay. Next, apart from the description, what all we should find out other than the description, their own words. As you know, this present history should be the history which comes from the patient, because others won't appreciate what exactly happens to the patient. It is just like headache. Headache, only the patient experiences headache. Only he will be able to give a description of the headache. Similarly, giddiness also only the patient will be able to say. The attendants will not be able to give you any history. And then we'll have to find out from the patient these following factors, which are also important. We'll see how they are important as we go along. That is, what was the onset like? I'll talk about it a little in detail later. What is the frequency? Most often, these episodes of M.G.R or giddiness is not an isolated event. It can be, but very often these are recurrent events in these people. So they would have experienced earlier also. So we should find out how frequent were there, and then how long does it last? Is it momentary? Is it for a few minutes? Is it hours, or is it days? These we'll have to find out. And similarly, what brings it on and what relieves it? See, it's very similar to the history which we take in a patient who has headaches. These are all the descriptions we get from the headache patient also. It is very similar for giddiness also. We'll have to say get all these details. Can I move on to the next slide, please? So I was talking to you about the description and what all we should get in the description, like frequency, occur mode of onset, and how often and how it goes, what are the associated relieving factors, etc. Now, from this description history, we shift a little bit to find out more information, and what should be comprising that more information. What should it comprise of? We'll have to find out whether this M.G.R, myocum, or the dizziness is acute. So once it has happened, or is it chronic? So is it continuous, that is chronic, or is it episodic or continuous? Episodic means it's an acute episode each time, but it is in episodes. So in between the patient is normal, or is the dizziness continuous? Another detail which we want to find out is the dizziness spontaneous? What do we mean by spontaneous? When there is no trigger. Now, what are the triggers? Triggers may be a loud sound. Triggers can be noise outside. Triggers can be positional changes. Triggers can be moving objects. Triggers can be getting up from the lying posture. So many of these are triggers. Or without any of these, just spontaneously, the patient could have dizziness. So we need to find out all this. Now, why should we find out all this? Because the more information we have, it helps us in finding out what could be the differential diagnosis for this patient with dizziness. How do we diagnose? You will see as we go along. And also this helps us to have a focused examination. We don't need to do elaborate examination. We can focus on what we need to examine and then proceed. Can I have the next slide, please? Next slide, please. Yeah, thank you. Now, all these symptoms, usually we call them as vestibular symptoms. I'll come to what is the vestibule and how what comprises the vestibule later. So the society, we have a society for vertigo itself, that is the Barani Society, which deals in broadly with vestibular symptoms. And they've defined that one is vertigo. Now, vestibular symptoms is vertigo. Vertigo, as all of you know, is the spinning sensation which the patient experiences. So that is, there is a perception of the patient himself spinning when obviously there is no movement. So that, or a distortion of the head movement when there is no movement. That is vertigo. Now, what is dizziness? The society has defined dizziness differently. What it says is dizziness is a lack of spatial orientation. Again, here also, here there is no perception of movement. Unlike vertigo, where there is a perception of movement, here there is no perception of movement, but the person is unable to spatially orient himself, or orient his head, or orient his body. And this is called dizziness. And both this vertigo and dizziness can, as we discussed earlier, can be spontaneous or triggered. I told you earlier itself about the triggers. These may be movement of objects, sounds, and sometimes orthostatic postures, or any positional change, like getting up, as I told you, these also could trigger. These are the triggers, and this is common. Triggers are common for vertigo and dizziness. Both can be triggered by these conditions. Now, what third one is the vestibulo-visual symptom. Vertigo, dizziness, and then we go to vestibulo-visual symptoms. Now, what is this? It is essentially an illusion. Visual means an illusion of symptoms, which has its origin in the vestibular system. So, and these illusions are essentially tilting movements. These visual symptoms will be that of objects tilting. They will not be able to focus, not able to see properly. They will say, oh, Mangala, Sariya Theriyala. Then you will have to find out again whether it is a double vision, or whether it's a blurring of vision, or whether it's a tilting of the images, or does the vision itself lag behind. So all of these are there. And this is what we call as when it's illusion of tilting of the environment, not within the patient, but outside. We call that as an external vertigo. And when there is a movement outside, we call it as oscillopsia, because the patient is not able to fixate. So the objects keep moving, and so that gives us a moving image, so which is called as oscillopsia. Right. Next, let's go. The fourth vestibular symptom is the postural symptom. As I told you earlier, as a neurologist, I see postural symptoms more often being described as M.G.R or Myogenic. Now, what are these postural symptoms? These postural symptoms are when the patient feels he is not steady. When I am crossing the road, I am not at all confident. I need to take somebody's help. I can walk on even grounds, but I find it very difficult to walk on uneven grounds, and I am afraid of crossing. And also, when walking itself, I feel imbalance at times. This is a very common complaint, and this also they say it's a M.G.R. And when then we ask him, is it a feeling of being pushed? Yes, tallud. That's a very common symptom description which they give for this M.G.R or Myogenic. Okay. Now let's go on to the next slide, please. The common recurrent type of giddiness which all of us come across and which all of us think of, as I told you earlier, is vertigo. Whenever patient complains with Myogenic M.G.R, it's concluded as vertigo, and immediately a prescription is given for beta histines, namely Vertin, beta, Z, whatever it is, or Stugeron, and patient is sent off. Now, even though the common type of this dizziness is vertigo, there are a number of conditions which can produce, as I have told you earlier. And the International Classification of Vestibular Disorders, in fact, that considers vertigo to be a separate entity and is not part of the widespread encompassing rubric of dizziness. So, according to the definitions put forward by this group, the vestibular symptoms need not have a structural or physiological relationship to the vestibular system. Now, I have to explain here what is the vestibular system. The vestibular system is namely the vestibule and the surrounding part. Now, what is the vestibule? Vestibule is that inner ear, a bony canal, which comprises of the saccule and the utricle. So that is the vestibule. But the vestibular system comprises of the vestibule as well as the surrounding feature in the inner ear itself, and those are the semicircular canals. So vestibular system is essentially the otolith organs, namely the utricle and the saccule and the semicircular canals. Now, what is meant by that phrase given there is the vestibular system symptoms which I had mentioned earlier, namely vertigo, dizziness, imbalance, all those need not necessarily be related to the vestibular anatomy or physiology. That means the same symptoms can be produced by involvement of other areas also. We will see those earlier. But however, they are all vestibular symptoms. Vestibular symptoms need not be coming only from the vestibule or the vestibular system, which consists of the vestibule and the semicircular canals. Now let's go on. The international classification, the same international classification of vestibular disorders, has also gone on to classify the disorders into syndromes. Why Always we talk of syndromes because syndromes helps us in coming to in formulating a differential diagnosis. It narrows down the differential diagnosis and we are able to formulate a differential diagnosis. So how is it classified? It is classified into acute vestibular symptoms, episodic vestibular symptoms, and continuous vestibular symptoms. This we saw earlier itself. Now I'll elaborate on that. An acute vestibular syndrome is, forget who coined it and all, it was in 1998. This obviously, when it is acute, it is sudden in onset. And what does it comprise of? Vertigo, dizziness, or unsteadiness. As I mentioned, these are the three principal descriptions which the patient gives. And this can last from days to weeks. An acute vestibular syndrome is acute, sudden in onset, but it can go on and on for days to weeks. And these symptoms are aggravated by neck movements. I told you about the triggers. And these are the neck movements. And very often, this is associated with nausea and nystagmus. This is the acute vestibular. So when the person presents with this sudden onset of this dizziness, giddiness, that is vertigo or imbalance, then what are the possibilities of these acute vestibular syndrome? See, differential diagnosis, we can narrow it down. Either it has to be vestibular neuritis, which is an inflammation of the vestibular nerve. It can be a stroke affecting the vestibular system, or drugs, toxicity of drugs. There are drugs which can cause damage to the vestibular system, and demyelinating disorders that can also be acute in onset. So these, after all, there are only 4 conditions which we commonly think of: vestibular neuritis common, stroke, drug toxicity, and demyelinating. So anybody presenting with an acute vestibular syndrome, these are the possibilities which we have to consider. Now, next we move on to episodic vestibular syndrome. Now, what do we mean by episodic vestibular syndrome? It occurs in episodes. Just like headache occurs episodically, seizures or fits occurs episodically. Similarly, this giddiness, vertigo, imbalance, all these can occur episodically also. They come, they go. They resolve spontaneously or with treatment. And then they, whenever they choose to occur, they recur. So these above symptoms, again, they can last for seconds, hours, or even days. And the differential diagnosis for this is, these are vestibular migraine is one. I can't talk about it. Then Meniere's disease, we'll talk about that also. Transient ischemic attacks, they can also present as episodic vestibular disturbance. And vestibular paroxysmia, this is a rare event. I'll talk about that also. So these are those which occurs in episodes. So those which occurs in episodes are principally migraine, less common Meniere's disease, less common TIA, and least common is vestibular paroxysm. And as you see here, this can be both peripheral and central, because Meniere's disease is a peripheral disorder, vestibular paroxysmia is a peripheral disorder, TIA is a central. Vestibular migraine, we don't know, most often it is central. So it can be mixed up, peripheral or vestibular or central. Now, what do we mean by peripheral, vestibular, or central? As I told you, the vestibular symptoms need not have relation to the vestibular structure itself. When it's the vestibular structure that is affected, namely the otoliths or the semicircular canals which are affected, then it's part of the peripheral vestibular system. Whereas if the central system, that is the brainstem, cerebellum, or the connection to these structures are affected, then it becomes central. So this is the distinction. We go on to the next slide, please. Let's move on to the chronic vestibular. Okay. So we looked at acute vestibular, we looked at episodic vestibular and considered the differential diagnosis. Now we go on to the chronic vestibular syndrome, which is this is the most difficult to treat also, and the conditions also like that. Even diagnosing those conditions and treating is a bit difficult. So what do we mean by chronic vestibular syndromes? There are some patients who come, oh, always this dizziness goes on. Every day I'm having dizziness, sir. From morning, the time I get up, I have this light dizziness. This is what they say. There, I told you, no, we'll look at what brings it on and what relieves it. So there is nothing, no relieving factors or no triggering factors in these people. So it can go on for months and years. There are a few patients who go on like that. And these are the patients who are put endlessly on labyrinthine sedatives, particularly Stugeron, which has its own toxicity. That is flunarizine, cinnarizine, which has its own toxicity if you continuously give it. But because these people constantly complain of dizziness, they are given these medicines by various practitioners and specialists, cardiologists, all. So what is the differential diagnosis for this chronic vestibular syndrome? The differential, there are a group of neurodegenerative disorders which can produce dizziness, as we shall see subsequently. And the another condition is this persistent postural perceptive dizziness, which is not known widely and not diagnosed frequently also. Very seldom you will find a diagnosis of persistent postural perceptive dizziness, even when the patients are being seen by ENT people. Most of these disorders which I've been discussing, most of these, as you can see from the differential diagnosis, come into the purview of the neurologist rather than the ENT persons. I'll talk about the ENT, but most often this is what happens. So any person who goes with this dizziness or gap, either seen by the practitioner or physician, then they themselves go to the ENT people or refer to ENT. And ENT people just look at the external ear. Very often there is nothing abnormal there, and they are said there's nothing to do with the external ear. And again, most often the diagnosis is benign persistent postural giddiness, BPPV, and they are put on sedative, labyrinthine sedative. But it need not always be BPPV. As we go along, we'll see the other differential diagnosis. So this chronic vestibular syndrome has a number of differential diagnoses: progressive neurodegenerative disorder, persistent postural perceptive dizziness, which is very seldom diagnosed. Then bilateral vestibulopathy. Again, rarely is it diagnosed as bilateral vestibulopathy. Stroke late effects, yes, some patients with stroke, they complain of myogenic dizziness. That may be, yes, that's diagnosed. Of course, when they have a cerebellar tumor, cerebellar ataxia, posterior fossa tumors, then it's easily diagnosed based on MRI, based on imaging. Now, generally, 60% of the dizziness is only due to peripheral vestibular disorders. The others are due to other causes. And amongst these peripheral vestibular disorders, the commonest things are BPPV, which I told you is benign persistent postural vertigo, positional vertigo, and vestibular neuritis, which is not that common, and Meniere's disease, again, not that common. So the common diagnosis everybody is given is whenever you go and see a case sheet, BPPV would have been written. But that's not the only cause. It may be common, but only in certain circumstances, depending on the description of the vertiginous episodes. Another thing which we have to accept and which we have to know, which we do not, is there are often two causes of dizziness. It need not be necessarily one cause. So there can be in a single person, they might have two causes or two conditions which can produce dizziness. And some of these are commonly seen in practice are this vestibular migraine, which is quite common and which only of late has come to be recognized even by the ENT surgeons and neurologists. Also, more we recognize, less commonly recognized by the ENT surgeons. Now they have come to terms with it to accept that vestibular migraine exists. And so they also, apart from their BPPV, they also diagnose vestibular migraine. The other is Meniere's disease, which is quite characteristic, which you can easily make out. We'll go into the features of Meniere's later. So Meniere's disease and vestibular migraine also can coexist. Similarly, vestibular migraine can coexist with this persistent postural perceptual dizziness. Then vestibular neuritis with vestibular migraine. So you see vestibular migraine coexists with so many of these conditions. And then vestibular neuritis and BPPV also can be there. So this can be confusing. So it's not necessary that only one of the disorders should be there. Can we go on to the next slide, please? Okay. So how do we go about diagnosis? As you know, both in medicine itself and especially in neurology, it is the recognition of the pattern. We go by the pattern. How does it come on? How long is it there? I already told you what was it onset, what was the frequency, how long does it last? So these are descriptions. These are pattern. Based on the pattern, we come to know, oh, this is likely to be the problem. So for this, two things are essential. One is we need to spend time with the patient to get a clean history. That always takes time, and many a time we don't spend that time, so we don't get that history. And second, the person who is taking that or seeing the patient should have considerable expertise or experience, should know, once they get the history, should know this is what it is on the examination. They should have the experience to skill to diagnose the condition. So both are required. That is a limitation. So, and once you apply this pattern to the syndromes, which I already mentioned, acute syndrome, episodic syndrome, or continuous syndrome, then it's not that difficult to come to a specific diagnosis. Another caveat is the vestibular symptoms, as I told you, can also overlap. The overlap can be between episodic and chronic vertigo. I told you about conditions which can overlap, disorders which can overlap, but also there are episodic and chronic syndromes which can overlap. So then you should know to diagnose which one of them or whether both of them are operative. Next slide, sir. So what are the symptoms? Description of the symptoms. Let's go to the description. This is really easy, you know that. Description of spinning, whirling, rotational, lifting, sinking, all these go with vertiginous symptoms. Okay. Which is due to a vestibular process. Now, other symptoms, I told you about this pre-syncope, no? Dizziness and lightheadedness, nausea, diaphoresis, particularly pallor with a feel of passing out, that is like falling down. This is pre-syncope. And these are characteristics of whenever a person gives that sort of a history of the dizziness, we should be aware that there may be a cardiac problem lurking around and should look at that underground background cardiac problem is there, whether there is any arrhythmia, whether there is any perfusion fall. These are this is where we need to focus our attention. Vestibular migraine, again, as there are many symptoms similar to vertigo, so I don't need to go into it. With Meniere's disease, how do we identify Meniere's disease? Meniere's disease is characterized by vertigo, and the other important symptom is the fullness of the ear or deafness. And more than that, these are people who are afraid to move at all. The vertigo is so severe, even a minimal movement causes the vertigo, and they're scared to move compared to other vertigos. So Meniere's disease, but the easy identifying point is they also have an associated hearing defect. And also a fullness of the ear. Next slide, please. Okay, having seen the description, next point I was saying about the mode of onset. I had already said that. So whenever a person has an acute vertigo, there are certain conditions which we can think of. That is a head trauma. If a head trauma is there, then it has to be an acute vertigo. What about symptoms?
கேஸ் ப்ரமோட் மாக்க பிஇபி சொல்லலாம்
மேம் பிஇபி நிறைய கேसेस இருக்கு
இல்ல, அது
4
அலெக்ஸ் சார்
கேसेस
சொல்லியது
இருக்கு
அந்த patient.
இல்ல 4 கேஸ் இருக்கு
அது மட்டும்
நான் எப்படி பண்ண முடியாது மேம் இது
A request to the host. Can you mute others?
அது மட்டும்
Just mute
Host,
பண்ணிடுங்க.
can you mute
Sorry
others,
sir,
please?
1 minute sir, 1 minute.
Okay, please mute.
யூசுவலா வராதல்ல எப்படி வந்துச்சு?
Okay, now say this is a very special situation. It's being recognized now, and sometimes this persists also. Of course, but persons who have gone on a cruise, a yacht or a boat or a ship, when they land, they have this giddiness or dizziness. This is specifically because they have the feeling of rocking as they are traveling, and even after coming, they have that. Usually, it is usually for a few days, but sometimes it can persist. So that is the mode of onset. We know we have to find out whether you are on a trip abroad, particularly in the sea. The next, of course, BPPV, as we already said, it usually happens with posture, particularly getting up, upright posture, bending the head, twisting the head, turning the head. This is the trigger for BPPV. So once that is the mode of onset, we know very likely it is BPPV. And any vertigo, that is equilibrium. I told you, there's disequilibrium or imbalance. Anything which is abrupt in onset, with that sort of a picture, we should consider a vascular event. Simple thing is make the patient stand. If the patient with the vertigo is unable to stand or falls to one side, we always should consider a central problem. It may be still a peripheral, but we'll have to consider that. Okay, duration. Whenever it is a few seconds only. I told you one condition, vestibular paroxysmia. It's not a common condition; it's a rare one. But then it's a brief period. I'll talk about it later about paroxysmia. It's a very brief period. part of seconds or seconds. And cardiac causes also, particularly if it's arrhythmia, then it can last only for seconds. But if the dizziness lasts for minutes, then it can be a TIA, as I told you earlier. Vestibular migraine, yes, minutes to hours. Panic disorder, again, person in panic may feel dizzy, and this also lasts for some minutes to hours. The delayed orthostatic hypotension, I'll talk about it later. That again lasts for minutes. Delayed orthostatic means normally when a person gets up, the BP falls down. Usually we signify 3 minutes time, but sometimes even beyond up to 10 minutes, they can have this fall in pressure causing hypotension. So also hypoglycemia can produce dizziness, which lasts for a few minutes. Hours, again, vestibular migraine, many years, conditions like toxic drug toxicity, metabolic factors, hyperglycemia, things like that can go on for hours. When it goes on for days, it can be vestibular migraine, maybe 2-3 days as with headaches. But vestibular neuritis lasts for weeks, days to weeks. And chronic, I've already discussed earlier. We have this persistent postural perceptual dizziness, and we also have this vestibulopathy and cerebellar degeneration. Next slide. Next slide. Okay, I talked about onset. I talked about what are associated. Then we go on to triggers. What are the triggers? Duration and then triggers. This Dick-Salpike is a specific position to bring on the benign postural vertigo. Okay. So that's a strong smell. Also can trigger, especially like in headaches, can trigger a vestibular migraine, visual or head movement. They can trigger. Orthostatic changes I already mentioned. When a person is put in standing position, it can trigger a dizziness. And what is POTS is postural orthostatic tachycardia syndrome. When the person is made to stand, they go in for a tachycardia. And this happens only on standing. And that can give rise to dizziness because it's like arrhythmia. And orthostatic hypotension, BP falls and the patient can become dizzy. Associated, what are the associated features itself? We talked about that also. No? What is the onset, what is the duration, what are the triggers, and what are the associated features? So the associated features are ear fullness. I told you already, when there is ear is full or muffled hearing, it's a feature of Meniere's syndrome, which is a cause of vertigo. And this is a cause of an episodic vertigo. Focal sensory symptoms. Whenever there is a neurologic deficit associated with the vertigo, we always think of an ischemic episodes, central disorder. Autophony is hearing of internal sounds. This is very characteristic. Spontaneously, people will hear internal sounds coming from within the body. That is called as autophony. And when it is there, it is characteristic of a condition called superior canal dehiscence. We'll talk about that later. That's also a condition where vertigo occurs. And that can be clinically itself diagnosed. Now, anxiety. See, anxiety can cause dizziness. Very well, yes, we know all that. A person who is hyperventilating or anxious very often complains, M.G.R, they would be either hyperventilating or be anxious with palpitations. So that could be one of the causes of dizziness. But other thing also, a person who has frequent dizziness or constant dizziness is anxious because of the dizziness itself. So anxiety can be is seen in both of these conditions. Next slide, please. Okay, now after the history, getting the history and paying attention to all those points, let's see what we need to do in the examination, clinical examination. Clinical examination, there isn't much to do. Any neurological examination, we'll have to focus on certain areas to find out whether the cerebellum or the brainstem is involved, because it is these two structures, when they are affected, produces a central cause of dizziness. Then ear examination. Ear examination also can be done by anybody. And the general otoscopic examination, what do we look for? We look for whether there is any cerumen which is staying there and blocking the ear, which can produce dizziness also. and whether there is any involvement of the tympanic membrane, either a perforation or the scar in the tympanic membrane, or whether there is any protrusion of a tumor like a cholesteatoma or a glomus jugulare tumor, which can protrude outside from the tympanic membrane. This can be visible by just doing an otoscopic examination, by examining the external ear. Then again, in the examination, I told you, we'll have to check for BP fall, because that is important. We'll go about it later to see how we do that. So now when coming to examination, neurological examination, what are the special areas we focus? We have to focus on how the patient stands, how the patient walks, and more importantly, what are the eye movements, whether there is any spontaneous eye movements or whether there is any provoked eye movements, which I shall talk about. Of course, articulation, because to find out whether there is any dysarthria, which all of these will indicate whether the vestibular system and the cerebellar system are normally functional. Now let's come to imbalance, which I have been talking a bit earlier itself, because many a patient say that their G.R and Myogenic, when you ask them, it's that they are not able to balance themselves or talra madri. Now this imbalance, there can be two things. One imbalance or and there may be a disturbance of the gait itself. And both of these could overlap. The person can have both also. Now what is imbalance? Imbalance is specifically related to the vestibular system and its connections to the cerebellar system. So, and it is also influenced by other two sensory symptoms. What are the sensory inputs to the cerebellum? One is from the vestibular, other is from the sensory organs, namely the sensory tracts, and third is visual input. So when these are affected, then the balance can be affected. But gait does not stop with this. For gait stability, we need more. Apart from balance, we need to cognitively judge what's happening, where are we, what is the surrounding, how do we need to walk, how do we need to walk, how do we need to move, what should be the speed of our movement, and similarly anticipating problems. And also orthopedic considerations, particularly osteoarthritis. So these people you would have seen, they'll have problems with the gait. So that is gait, which is much larger than only imbalance. So these are the features which you should look at. And again, falls. When falls happen, this can be due to sensory involvement or due to a vestibular involvement. And that is when we check with the Rombergs. Rombergs usually is making the patient stand with feet together and asking to close his eyes. In a person with a sensory problem, because of the sensory ataxia, the patient is likely to fall. But also in people with the vestibular symptom, the same thing happens. Not only sensory system, vestibular system, if it's not functional, also they can have problems with standing with feet together and eyes closed. So that can also result in falls. So that's about Romberg's test. And next slide, please. These are the examinations which we need to do. Next slide, please. Okay, this is an important part, but I will touch in brief because this is mostly, it's a neurology part, not common for others. They find it difficult to do this, but I'll just let you know what are these. We'll have to look for eye movements and nystagmus. I'll come to the nystagmus later. Eye movements, okay, just look at the eye. What is the normal position? If the eyes are deviated to one side. Now, what is lateropulsion of saccades? This is difficult for you. See, when we ask the patient to move the eyes, they have to move the eyes equally in both directions. But sometimes the fast movement is what is called as a saccade. In certain conditions, the fast movements, the lateropulsion, in what happens in lateropulsion is it undershoots, that is, it moves less in the opposite direction and moves overshoots in the direction which they are looking. Why is it important? It is characteristic of a particular syndrome, the lateral medullary syndrome. Once we see that, we can say this patient has a lateral medullary infarct. As I said, these are for neurologists, so I won't go much into it. Let me also dismiss saccadic dysmetria, which is also difficult for others. Persistent skew, this is important. What is skew deviation? When you look at the eyes, there will be a misalignment of the eye. One eye will be looking up, the other eye will be looking straight. When we see a misalignment of the eye in a normal person with vertigo, it indicates that there is an involvement of the midbrain and it's a central vestibular syndrome, central vestibular involvement, which most often occurs in stroke. The importance is once you see that sign, you know it is a stroke. We leave around that. Next, coming to nystagmus. Nystagmus is that oscillatory movement of the eyes which you can make out. It can be spontaneous, gaze related, or positional. I have to talk about it a little bit, especially positional, because again, when we examine a person with vertigo, we necessarily have to look for this. So it's common for whomsoever examines a person with vertigo. So that you should know. So I'll deal with it later. Again, spontaneous downbeating is nystagmus which beats down, nystagmus which constantly beats up. These are all indicative of a central pathology. So we'll forget that. This again is technical. I won't go into horizontal nystagmus. What is Alexander? We'll omit that also. You can go on to the next slide, please. Okay. So how is this diagnosed? This is important. I told you with regards to eye movements and nystagmus. Whenever we ask a person to look in one direction, he looks to the right, there is a nystagmus. We ask him to look to the left, there is a nystagmus. This is gaze evoked nystagmus in the direction of the gaze. Whenever that happens, it means that the pathology is central, not peripheral. Okay. Now, positional nystagmus. This is gaze evoked. Now, positional. What do we mean by position? Positional is position of the head. When you position the head in a particular posture and you elicit a nystagmus, that is positional nystagmus, and this is an indicator of a peripheral nystagmus, most often seen with PPPV. Okay. Now, how do we look for this nystagmus? We can look with a naked eye, but many a time we may not be able to identify the nystagmus. I'll tell you why. So we need to have a Fresnel glasses. It's not easy to acquire a Fresnel glasses. Not every practitioner, not every hospital even has a Fresnel glasses. Now, when we look at the naked eye, the patient might be fixing his eye. So when they fix the eye, the peripheral type of positional nystagmus is not seen. Very rarely is it seen. So we might miss it. But when we wear a Fresnel, when we ask the patient to wear a Fresnel glasses, what happens? It blocks the vision. The patient is unable to fix. And when we see from outside, we can have a look into the person's eye. We'll find the nystagmus occurring. So it becomes easy. Of course, this Fresnel, I won't go into the technical infrared and optical. That's not necessary for us. Sometimes even if we don't have a Fresnel glasses, with the ophthalmoscope, we can do the same thing. We cover one eye and then look through the ophthalmoscope, we can detect the movement. So then we know that the nystagmus is there. Neck vibration test again is another way of testing for the nystagmus. Again, I won't go into it because it's not for everyone. So we'll quit on that and save time. Next slide, please. If somebody has a question, I'll answer on that. Now, this is a fairly simple test which every one of us should be familiar about and which we should try and do it. This is called the head impulse test. This is very similar to what we do in a comatose patient. We do the doll's eye maneuver. Move the eye from side to side and see whether, move the head from side to side and see what is the direction of the eye movement. It's the same phenomena which we see in a conscious patient also to test the movement of the eye. What we do is we fix the patient's head, as you can see, with our hands straight and ask the patient to look at our nose, examiner's nose, and we then move the head side to side quite briskly, not much, only about 10 to 15 degrees, but from one side to other side, and that too it has to be done a number of times. Now what happens is, when I move the eyes and ask the patient to fix it on me, when I move the patient's head, the patient's eye should remain fixed on my nose. There should not be any, the movement is the eyes are fixed on my nose. But supposing if the eyes move in the direction in which I move the head and then comes back to fix on my nose, then that is defective. So that side is not functioning properly. The vestibular apparatus or the vestibular nerve is not functioning normally. This is a simple test to find out the efficacy or integrity of the vestibular nerve on that side. Now, one thing which we have to remember is this test is applicable in persons who have vestibular neuritis because the vestibular nerve is damaged. But what about persons? The common situation is this benign persistent postural vertigo, where what happens is it's only positional and it's transient. So what happens is the nerve is not necessarily damaged. And at the time when we do, we may not be able to pick it up. So that is why we need to do the Dick-Salpike maneuver to elicit the nystagmus rather than this head impulse test. The head impulse test can be normal. Quite often it could be normal in persons who complain of dizziness or even vertigo episodic. Because at that time, if they don't have the vertigo, this test is not going to be positive. Okay, next slide. That's the limitation of the test, but it's a very simple test which can be done. But if there is a vestibular damage, either unilateral or bilateral, then it can be easily identified by this head impulse test. Next, head impulse test is a bedside test. Now, this is an investigational test. Vestibular evoked myogenic potential. Now, what is vestibular? This you see, anybody who is somewhat interested and into this evaluation of this dizziness or vertigo, they have to be familiar with this vestibular evoked myogenic potential. Nowadays, what happens? Sophisticated clinics have come or labs have come where they are doing a battery of tests on persons with giddiness and vertigo. You will see giddiness clinic, vertigo clinic, just like the audiology, audiogram being done, speech and hearing. Similarly, those same people run these lab also, doing the vestibular system. Tests of the vestibular system. So you should know which of these tests are going to be really helpful to us and when we should ask, and what is the limitation or what is the usefulness of these tests. See, for example, this vestibular evoked myogenic potential can be of two things. One, it can be cervical or it can be ocular. Now, what we mean by cervical is neck. So when we record the potential from the neck muscle, sternocleidomastoid, it is called as a cervical vestibular evoked myogenic potential. Now, when we record ocular, that is the eye movement, by placing electrodes below the eye, that is called as ocular vestibular evoked myogenic. So what we do is we give some sounds to the ear, each ear, and record it from the muscle, respective muscle, and see whether there is reduction in the potential or amplification of the potential or absence of the potential. Based on that, we can draw some conclusions. Now, essentially, in summary, the vestibular evoked myogenic potential is most often helpful only when there is a superior semicircular canal dehiscence. I told you one of the conditions where vertigo is, this is an ENT condition, where there is a dehiscence in the vestibule itself, in the canal, and that is the superior semicircular canal. In this condition, the ocular vestibular myogenic potential will be affected. So that is the only situation where these VEMs are helpful. The cervical VEMs are most often normal. They are subserved by the inferior vestibular nerve. And even in vestibular PPPV or vestibular neuritis, it's not often involved. Whereas the superior vestibular nerve supplies this ocular vestibular myogenic potential, and that is abnormal in superior semicircular canal dehiscence, and sometimes in certain semicircular canal involvement also, but not always. So its definitive utility is only in superior semicircular canal. And so very often we all the patients are submitted to this VEM with no reliable information coming out. Next slide, please. This is very often not known to many people. They just order a VEM, that's all. Now, video nystagmography, this is a much more specialized investigation using a video, and we record electrically the nystagmography. This is a relatively troublesome procedure both for the patient and the person doing it, because it includes two tests. We do what we usually call as a caloric test, when we inject water, either hot water or cold water, and induce vertigo. That's the problem. We induce vertigo, which can be very troublesome for the patient with the vertigo, and they don't like it. They go also throw up, they have nausea, and so it's a messy affair. And the information we get out of it can be, nowadays we got out of other tests itself, namely the head impulse test, and using a frontal glasses and finding out with a video recording. So not very often is it used. And see, as I mentioned, it's helpful only when the horizontal semicircular canal is involved. And the horizontal semicircular canal is not always involved. It's a rarity. Whereas it's the posterior semicircular canal which is commonly involved. But when we do a video head impulse, what I told you is a head impulse test which we manually do at the bedside. But there is a video head impulse test also, which I'll talk about later, show you. In that, you can test all the three semicircular canals on both sides. That is more informative. Okay, next slide, please. This again is only a test for horizontal semicircular canals. This is only for conclusion. It's an expensive equipment, and I don't think we normally go in for this. Next slide. Now, one more point on examination. This is HINS. What does HINS stand for? Head impulse test, nystagmus, and the test of skew. This is where the skew comes. Now, I already told you skew is a misalignment in the vertical plane of the eyes in normal position. So once that is there, we know it's a skew. And that, if it is present, the HINS, that is head impulse test, is negative, indicating there is no peripheral involvement. And if there is nystagmus, which could be peripheral or central, and the skew is positive, then we know it's a central involvement, most likely a stroke when it is an acute vertigo. And what helps further is this HINS plus. In HINS plus is doing an audiogram. And in this, if the patient finds an audiogram also to be affected, the hearing also to be affected in an acute vertigo setting, then we are very sure that it is a vascular involvement of the anterior inferior cerebellar artery affecting the vestibular system, vestibular nerve, to the connection to the brainstem, and also the auditory. Both are involved. Okay. So this is the importance of this HINS examination. Next slide, please. Now, coming to the last part of it, the tilt table. I told you about the orthostatic part of it. Normally, when we look for orthostatic hypotension, what we usually do, all of us do, is we just wait for 3 minutes and check the blood pressure. But many a times they have done a test, and as I have shown you here, 40% of the patients did not show hypotension until they stood up for at least 10 minutes. And so this is where the tilt table helps. The patient is tied to the table so that they do not move, and the table is inclined to a vertical position. And with that, we monitor the blood pressure. So when such is done, and when the person show a delay, that is a fall in blood pressure after 10 minutes, then it indicates certain conditions which particularly neurologists we need to be concerned about, because in a third of such patients, it indicates a synucleinopathy. What we mean by synucleinopathy is either Parkinson's disease or a multisystem atrophy or a Lewy bodies. This is for neurologists. So that test can be a harbinger pointing out that it might be this problem. Okay, next move on to the next slide, please. Okay, what about imaging? How helpful is imaging? Yes. In superior semicircular canal dehiscence, yes, imaging is important, where we do a look at the temporal bone, CT bone, and particularly also when there is a tumor, as I told you, cholesteatoma, glomus jugulare tumors, I already mentioned. When these are there, then it can be picked up on the CT scan. Now, what about the MRI? Yes, when it's a posterior fossa tumor, when the cerebellum is affected, when there is a stroke which is involving the brainstem or the cerebellum. So whenever we think of a central cause of vertigo, we do an MRI imaging. And when we think it is in the bony canal bone, then we do a CT scan. Next slide, please. Now, what about some blood tests? Do we have any role for the blood tests at all? Seldom is it helpful, but in certain situations, blood tests can help. And what are these conditions? The ASM is anti-seizure medication. Whenever a person is on anti-epileptic drugs, which is anti-seizure medicine, they can have, when there is a toxicity, they can have nystagmus and they can have this M.G.R, dizziness, Myogenic, all this. So in them, we'll have to test the levels of the medication to find out whether it's a toxic level that is there and that is causing the problem. Similarly, low B12 or methylmalonic acid, which is a confirmation of a low B12, that can also cause vertiginous episode. Metabolic conditions, I already told you, sugar related problems, thyroid related problems can cause imbalance in patients. Similarly, in those with orthostatic, when they are made to stand up and find that there is a dizziness, apart from a fall in blood pressure, we also need to monitor the blood counts, whether there is any abnormal blood counts in them, and also the metabolic panel, as I have mentioned above. Now, what about hearing impairment? When a person has hearing impairment, and that too is bilateral, and when they have vertigo also, certain special tests need to be done in the blood, particularly for syphilis. VDRL serology is required, and anti-nuclear antibody screen and ESR to find out about the antibodies, autoimmune antibody syndromes causing these problems. And when a person is ataxic, there are certain select antibodies which can, like the G, this is again for neurologists, GAD65 antibodies can be abnormal in person with ataxia and vertigo, and so also vitamin E levels. See, I'm covering all groups of people, not only a select group of people. So I have included all tests that are usually done. Okay, next slide, please. Now moving away. Okay, now how do we analyze? There are so many investigations I have listed out, but how many of them are useful? How many of them is needed? Let's see what, this is my assumption. I mean, my conclusion. See, though peripheral causes are common, at least in 60%, half of these have a non-vestibular mechanism. I told you, no, even though it's a peripheral vestibular symptoms, the vestibular symptoms need not have an involvement of the vestibular mechanism, that is structure or physiology. And so you may not find anything abnormal in that. And not alone that, and out of these people, that is half who have a non-vestibular mechanism, 1 in 6 or 1/6 have 2 different causes. So you can't pin on one cause also, even with those investigations. Now, what are the tests which we are doing? We are testing the otolith organ, namely the saccule and the utricle, which is where we use the WEMP. Okay. And then we have, say, 3 semicircular canals for which the best use is the head impulse test, video head impulse test. We can also use the VENG and rotary chair. But these are the means by which we interrogate them or quantify the involvement. Out of these, VENG, rotary chair, and video hit are tests for superior semicircular canals, as I just said, whereas the WEMPs assess the otoliths, namely the utricle and the saccule. So only they are helpful as far as that condition is concerned. I already said the WEMPs are only when you suspect a superior canal dehiscence. Every patient who has a giddiness, who goes to an ENT, sophisticated ENT person or a lab has the WEMP, or even the neurologist has the WEMP test done. I do not know. Sorry, I have mentioned the relevance. It is up to them to judge whether it's helpful or not. It's helpful only in this condition. Otherwise, it's a dubious entity. Now, again, amongst the semicircular canal tests, it's only the video head impulse test which is informative, and many of us do not have that video head impulse test. Rest are all, well, questionable. And amongst the vestibular disorders, see, again, BPPV, vestibular migraine, and vestibular intrahepatic Meniere disease, out of these conditions, 4, which are the common vestibular disorders, only BPPV and vestibular migraine are common. However, both of these are episodic. So when you do the test, they may not have the episodes. And so there may not be any abnormality at all. You may not pick up anything. So when are they abnormal? They are abnormal only when the vestibular nerve is damaged, as in vestibular neuritis, or when there is a dehiscence of the semicircular canal, again a damage. Only in those conditions, anytime you do the tests are likely to be abnormal, provided you choose the ideal test to be done in them. But I am repeating ad nausea, but doesn't matter. WEMPs are useful only when there is a dehiscence of the superior semicircular canal is suspected, and it is confirmative. Once it is abnormal, it is confirmative. And when a person is having a vestibular neuritis, again in that person, the hit itself is abnormal and it's confirmative. That's all. The rest of the things are, as I said, questionable use. So it's up to the person asking for him for those tests to utilize his judgment and ask for it. Imaging, again, yes, whenever we suspect a central pathology, necessarily we'll have to have an imaging done. Next slide, please. This is my assessment of the investigations. Each person may draw their own conclusion, they may have their own judgment. Okay, now from the examination, clinical examination focusing on the history and examination, and then the investigations. Last bit, I'll go on to what are the conditions which can cause the symptoms, vestibular symptoms. I did mention about vestibular paroxysmia. I told you I'll talk about it. This is very similar to trigeminal neuralgia. What is trigeminal neuralgia? It is a paroxysmal, lancinating, sharp pain just for few seconds, just like a click, and then disappears, which comes on in one part of the face, either the mandibular division of the trigeminal nerve or the maxillary division, more common. That is where this happens. It's very similar. It happens because there is pressure, neurovascular compression over the vestibulocochlear nerve also. And this was also described by the same person, Janata, who described trigeminal neuralgia. And here also, carbamazepine and other anti-seizure medicines are helpful. Now, what about benign recurrent vertigo? I just brought in this term because sometimes recurrent vertigo, as I already told you, these are episodic vertigo, and when there is no associated features, the common thinking will be migraine. So sometimes we try to differentiate that not necessarily all recurrent vertigos have to be migraine, because the persons do not have history suggestive of migraine. So when do we suspect migraine? When the person also has an associated headache, that is migraine episodes, or when this vertigo is associated with a headache, or they have some special triggers which are operative, as in headache, special triggers which are operative in these people also, then of course, then it's likely to be a vestibular migraine, even though it's a benign and recurrent. Now, without those being there, some patients have recurrent vertigo, but it is benign because it does not cause any other damage. However many number of times they have this vertigo, there is no neurological damage on examination. We find the neurological examination to be normal. So there is such an entity, but we do not know more about it. That's why I mentioned that the nosology of this entity needs to be established. We still do not know, but it is recognized. Panic attacks, I've already told you. Dizziness can cause panic attacks, and panic attacks can cause dizziness. It's quite common in young females. They become panic, and whatever the cause of the panic, hyperventilation, all these can produce dizziness. As most often, you know, hyperventilation results in dizziness also, and which we think it might be seizures, which they can result in loss of consciousness, producing all sorts of confusion for diagnosis. One thing about panic attacks, this again, patients who have this dizziness, they feel uncomfortable when they are moving in a crowd, when they are going to a crowded hall like a mall, when they are in a cinema theater, when there are lots of crowd around and these people are moving around, they feel very uncomfortable. So that is where this movement is related to this dizziness, and then it causes a panic in them. They feel that they may get dizzy or fall down. That is one source of panic attacks. This is not uncommon. People will give this history. Next slide, please. Provided we look at such people often. Okay, now coming to this persistent postural perceptual dizziness. This, as I told you, is not known to many people, and it's a difficult diagnosis, virtually not known to the ENT people. And it's a major diagnostic entity, however, but it's a chronic dizziness condition. And in fact, the diagnosis criteria itself was established only about 5 years ago. We don't need to go into the criteria, you can always look up. But the persistent symptoms are exacerbated by 3 factors. Very important is the upright posture. This happens only in upright posture. And as I told you, active or passive motion, either the patient moves or the surrounding moves. And just like in panic attack, I told you, there's constant movement of people that produces this. It overlaps with the panic, persistent postural perceptual dizziness in this patient. They can have an element of panic and anxiety also. And one thing is, clinically, these patients, however chronic it is, they do not fall. There is no fall in these patients, but it's incapacitating, it's limiting them from their movements. And most often there is a trigger, and that trigger could have been an acute vertigo, an episodic vertigo, or a chronic vertigo, which could have happened in the past, continuous vertigo. And that happens to be a trigger, and that settles down. But following that, the patients experience continuous persistent perceptual dizziness. So this is an entity which we have to look at, not known to many, but it does exist. Next slide, please. Particularly in those who complain of dizziness always. Next slide, please. Now coming to some of the rare conditions, bilateral vestibulopathy, not that common. As I said, uncommon. And it's also difficult to treat when both vestibular nerves are affected. Okay. When this is uncommon. And this again, how is it diagnosed? When the person becomes unsteady only when he is up, that is upright, walking or standing. And when there is any movement induced blurring of vision, I already told you, there can be blurring of vision, which can be part of this vestibular syndrome. And they'll feel as though the objects are oscillating, moving. And this also I pointed out was worsening of unsteadiness in the dark or uneven ground. They'll find it difficult to cross the pedestrian crossing. They feel that they are able to walk on level grounds better than uneven grounds. All this is a symptom of vestibular syndrome, I told you already, but it's much more when there's a bilateral vestibulopathy. Very often the cause is not known, but there are some genetic conditions. There are degenerative conditions also which can produce bilateral, and some autoimmune. And this is a rare one, but for the interest of neurologists, I mentioned that there is cerebellar ataxia neuropathy with vestibular areflexia, which when you find that the head impulse test, when it is absent on both sides, is indicative of bilateral vestibulopathy. Okay, next slide, please. The rest of the things are not of interest to non-neurologists, so I'll skip that. Let's go to. Now, this is of interest to the ENT people. This is a light cupola syndrome, which very much resembles a horizontal canal BPPV with intense vertigo. And this is because the cupola becomes light, particularly in alcoholics. And this is diagnosed based on a nystagmus, a type of nystagmus which we should not go into. It's called as geotropic. When the nystagmus is, when the head is turned, it beats to the ground. So these are specific conditions. So I just mentioned it and leave it. Superficial siderosis, again, a person having recurrent hemorrhagic conditions. They have hemosiderin deposited, and this can, in the vestibular nerve, if it is deposited outside or inside, they can produce. That's why it can cause peripheral and central. Then it can produce dizziness again. These are some of the, just to mention the conditions which can cause. Neurodegenerative, again, for the neurologist, it's important, and for others also. Many a times we do not recognize this, but it's there. It has been there. It has not been recognized. But very often, people, particularly with those with Parkinson's disease, they do complain of imbalance. They do complain of this dizziness, and that's mistaken for being not a part of Parkinson's disease. But we now know that it's a non-motor part of symptom of Parkinson's disease. Also, though still not in the text, it has not been mentioned much. But in practice, we see that not uncommonly. Next slide, please. Now, lastly, coming to some of the autoimmune, as with anything else, the autoimmune phenomena have come to a large scale now with investigating and picking up autoimmune antibodies. And so there are antibodies which can target the vestibulocerebellar pathways. Just like they target several structures, they can target specifically the vestibulocerebellar pathways or the vestibular nuclei. And these can be either related to neoplasms, namely paraneoplastic or non-paraneoplastic. These paraneoplastic, these are all common. You might get it anywhere. This is common for any paraneoplastic conditions. And similarly, vestibulocerebellar disorders also can be due to the involvement of the vestibulocerebellar structures by paraneoplastic autoimmune. This can be other antibodies also, particularly this Casper2 or voltage gated calcium channels. So they can also produce this. So both neoplastic and non-neoplastic. Now, what are the autological conditions which can cause vertigo? See, these are again common. Meniere's, I already talked to you. Superior semicircular canal dehiscence also, I talked to you. But Ramsay-Hunt syndrome is again an infection of the external ear, mostly due to herpes infection, which can cause a facial weakness and vesicles. And because of the ear involvement, they can cause vestibular symptoms also. Cholesteatoma is something growing in the ear, and because it presses on the vestibulocochlear nerve, it can give rise to the vestibular symptoms and also hearing. Perilymphatic fistula is very much like Meniere's disease. Perilymphatic fistula and Meniere's can be easily diagnosed. They are almost similar, but what is important, I'll talk about it later. I think there is a slide. See, both Meniere's disease and perilymphatic fistula can sometimes produce sudden falls. That is, it can cause a severe vertigo, making the patient falls. These are called a Tnmgrmu falls. Once they are there, it not alone is a diagnostic point, it also means that the vestibular nerve has to be ablated. Otherwise, it will produce recurrent falls, and these people are likely to injure. And this happens in two conditions, namely Meniere's disease and perilymphatic fistula. Semicircular canal Dizziness also is one of the features with perilymphatic fistula. Paratrauma, air pressure causing trauma, which is particularly common in people who dive, come up. Sometimes nowadays it's also recognized in people who travel in airplanes and then come down. They also have this dizziness as a result of paratrauma. Enlarged vestibular aqueduct syndrome, not known much, not talked about much. I'll have a slide on that. I'll show you. And so also Cogan syndrome. Can we go to the next slide, please? Next slide, please. Yeah. So this is what I was telling you, Meniere's. I just wanted to mention about the Tnmgrmu falls. That is severe vertigo making them fall. And there's no loss of consciousness. And that happens in Meniere's, and it's important because they'll have to ablate the nerve itself. Now, talking of this enlarged vestibular aqueduct, this is a rare condition, not well known, not recognized also. That is because the vestibular aqueduct, I told you the vestibule is a bony canal, and there is an aqueduct there. It's a slit-like aperture which connects the bony canal with the vestibule and the endolymphatic sac. That is enlarged. Because of that, there are pressure changes within it, and that causes both hearing loss and recurrent vertigo. This simulates a Meniere's disease. So this is all usually for ENT surgeons there. But how is it diagnosed? A CT scan of the temporal bone, as I was mentioning, should be sufficient, or an MRI of the internal auditory canal can diagnose this condition. Cogan is an autoimmune condition which involves the eye and vertigo and tinnitus, usually in a female in the age group of 20 to 40 years. This is a vasculitic condition, and the importance here is they respond very well to steroids. That is why I mentioned that here. Next slide, please. That's it. I come to the end of my talk. Just some key points. Vertigo and dizziness are not necessarily the same, so they have to be separated. The description is different. And yeah, same thing, vertigo is not a subset of dizziness. Dizziness is impaired spatial orientation, whereas vertigo is a symptom of motion, illusory motion. Syndrome categorization helps in narrowing down the differential diagnosis, as I showed you: acute syndrome, episodic syndrome, or continuous syndrome, chronic syndrome, sorry. And a thorough history, as with anything in neurology, a thorough history is important. And this helps us in focusing our examination to certain crucial structures, and so also the labs. Labs are only confirmatory. They are not primarily telling you the diagnosis. So the key examination focus on examination include eye movements, gait, that is how they walk, the eye movements, nystagmus, and bedside tests of vestibular function, which is what I mentioned as the head impulse test. And gait is also important, balance and gait. So a logical differential diagnosis can be derived by recognizing the patterns or the near patterns in the clinical history. With that, I end my talk, and thank you very much for the opportunity given. And I think I owed you for a sufficient length of time because I was given 2 hours. I thought I'll utilize it in explaining it. Now I am prepared to take questions, and I open it to the panelists. Panelists, you can take over, sirs. Thank you very much for the patience.
Thank you, sir. Thank you, sir.
Thank you. I should thank you for your
teacher.
patience.
Sir, I thank my teacher, Professor Natarajan, sir, for the elaborate and detailed talk on approach to dizziness. With this permission, I just sum up a few points, sir.
Please,
So
you're welcome.
dizziness is the common symptom encountered by all practitioners. Dizziness which includes a lot of descriptions in the form of vertigo, lightheadedness, disorientation, pre-syncope, postural instability, mental confusion, and generalized tiredness. Actually, vertigo is the recurrent and troublesome type of dizziness. We have to recognize the pattern of dizziness, which gives the differential diagnosis. It can be subjective or objective vertigo, that is rotation of the head or the surroundings, which is called objective. So vertigo can be brief, it lasts for a few seconds or minutes or hours, can be recurrent. Occasionally it lasts for a few days. Most of the recurrent vertigo are benign. We need not worry about it. Acute onset of vertigo with nausea or vomiting, which indicates vestibular neuronitis. If it is associated with deafness, which is called labyrinthitis. If the vertigo is associated with sweating, recurrent vomiting, palpitation, which indicates peripheral vestibular involvement. The common type of cause of vertigo, the condition is benign BPPV. Actually, it's a BPPV. Sir has discussed in detail. The other common cause of recurrent vertigo is vestibular migraine. So the vertigo associated with headache occurring together or vertigo with photophobia and triggered by triggers of migraine, in which the vertigo lasts for minutes to an hour with fluctuating intensity. See, the other causes of dizziness are TIA, one of the differential diagnoses, for a brief episode of dizziness. It never occurs with dizziness, usually associated with other symptoms like visual disturbances, confusion, and altered sensorium. The other non-vestibular systemic dysfunction, the cause of dizziness is pre-syncope, where in which the patient will have dizziness, darkening of eyes and blurring of vision, sweating, tachycardia, which occurs only on standing, which lasts for a few seconds to a minute, which is called pre-syncope. The other differential diagnosis, as saw discussed in dysautonomia, mainly in diabetes. The commonly people will come with answer also. And I have giddiness. The cause is cervical. It's a misconception. It is because of the altered proprioception input from neck due to facet arthropathy or cervical radiculopathy. And actually, the compression of vertebral artery is rare in this condition, which manifests with brainstem signs. Then some of the drugs also causes dizziness. The aminoglycosides, benzodiazepine, the antipsychotics, and commonly used diuretics. So with this, I just pass on to Professor Jawgar.
Sir, Professor Veetrajan, sir. So you
Yes, sir.
elaborately, extensively dealt with the entire, all aspects of vertigo. Vertigo itself, it consumes one big textbook, sir. You have covered everything almost within an hour, not leaving any single part, sir. It's a really good lecture. I never heard such a complete lecture on vertigo so far. Thank you very much, sir. Thank you
Thank
very
you,
much
sir.
for
Thank
your.
you very much. I tested
Thank
your
you.
patience. Everybody's patience.
Any questions from audience? Other participants? If there are no questions, then we can close the session. Thank you, sir. Thank you so much. It was very extensive discussion. And thank you, Dr. Mukundan, sir, and thank you, Dr. Javadar, sir. It was wonderful.
Thank you,
Summarizing
ma'am.
all the points.
Thank you.
Thank you, madam.
Thank you.
Thank you, sir.
Thanks the staff of the university and the VC of the university for having asked me to give this talk. I hope I have not tested the patience of all of you. But
No,
I
not
think,
at all, sir.
but I think I had to, as I said, bring out all the conditions and as Jawahar said, include everything so that it is more comprehensive. Thank you, madam.
Yes,
Thank you,
sir.
sir.
Thank you, sir. Thank you so much.
Thank you, ma'am.
Thank you. Thank you, Mukundan, and thank you, Jawahar.
Thank you, sir. Thank you very much, sir.
Sir, you are always there.